Hi everyone, and thanks for tuning in to this presentation about image evaluation and quality. And this entire presentation really takes into account everything we've learned up to this point so that you can look at your image, use the knowledge that you have about positioning and film critique, and decide, does it look good enough for me to send it through to a radiologist? So objectives for this presentation, just overview of image evaluation and quality. We're going to look at sharpness of detail and all of the components of that versus the visibility of detail and the components of that. We're going to look at exposure errors, which leads into exposure indicators, and then how to correct errors. So the quote for this presentation is, "Quality is not an act, it is a habit." And this one, I cannot stress enough how important it is to go ahead and get into healthy habits so that when you're out on the floor and you're in a stressful situation, you have a patient that's coding, you have a list a mile long, there is a trauma alert being called in the ED, name everything that would stress you out and put that on your list. But then you have your habits that you fall back onto. You have your muscle memory. You have the checks that you always do to ensure that your images are high quality. So, radiographic image evaluation and quality. Evaluation, just making a judgment of our image. Is it good? Is it worth sending through to be evaluated, or do I need to take a repeat? Do I have my objective? Does it look super bright? Is the contrast appropriate? Quality is the degree of excellence and diagnostic usability of an X-ray. This is a definition that I created in conjunction with Merriam-Webster, our lovely dictionary service. So our X-rays have to be diagnostically usable. Meaning, if you look at this X-ray that I'm showing you right now, I can't see bony trabecular pattern. If I was trying to look for a small fracture in my carpals, there is no way that I would be able to see anything happening in here. It's way too bright. I don't have a long enough scale of contrast to see bony trabecular pattern. So ultimately, we evaluate our images for quality and decide whether to send them through. And so we are the ones deciding the quality that a patient is going to receive. So it is of the utmost importance to send the best image that can be obtained to PACS or MEMS so that radiologists can read these images, not miss fractures or other injuries or disease processes that may be happening. That way, patients can then get the treatment that they require as quickly as possible. So a great example of this is why I do X-ray at all. I was in a car accident and broke my tarsal bone, and the first place that I went to took an X-ray, didn't see the fracture, and fast forward to I got sent to a different hospital, and this hospital took the time to really look at my images, ensure that they had quality images. They even showed me my X-rays, which I had no idea what I was looking at the time. But they were able to identify the small fracture in my tarsal that ultimately led to me having to have surgery because the tarsals are finicky little bones. Their blood supply is complicated, and so they're harder to heal. But my surgeon told me that missing that fracture could have ultimately led to pretty severe arthritis, if not a total ankle replacement. So these are the kind of repercussions that can happen from taking images that are not of diagnostic quality and sending them through to a radiologist. You're compromising patient care, so please make sure you're taking the time to build these habits and send through quality images. All right, so our image quality is determined by two things. We're going to have sharpness of detail and visibility of detail. And now, sharpness of detail is specifically looking at things related to spatial resolution and things that affect spatial resolution. So the two things here are going to be geometric factors. And so when I say geometric factors, I want you to think of something that you can actually measure. So magnification, there is a magnification formula where we actually are able to put a value to how much magnification is in our image, as well as distortion. So distortion, think of elongation, foreshortening, things like SID, our angle. Those are things that can add to or prevent distortion. So geometric factors, think of spatial resolution, think of something you can measure. Mechanical factors are going to be things related to our actual detectors, our actual equipment. So these are going to be things like pixel and del size and pitch, which we can measure that. Matrix size, so we are able to look at resolution size. And then our modulation transfer function, which relates to spatial frequencies. Then we're moving over to the other side where we have visibility of detail, and I want you to think of this as what can I actually see? Is it super bright like this image here? Or do I have a lot of grays, long scale contrast where I can actually distinguish bony trabecular pattern and I can detect the density of adjacent structures. I'm also thinking of noise here. I'm looking at it, like, is my detector receiving enough signal? Do I have enough technique actually getting through the patient and reaching my detector? Do I have the bit depth built in to actually see all the varying shades of gray? Is my system actually, my actual detector, working properly and all its components working properly so that it's turning my signal, the x-ray that I'm sending through the patient, is it picking it up and turning it into a usable x-ray? And that relates to exposure latitude. DQE, that measure, is what allows us to have such wide exposure latitude, such wide dynamic range. And so this relates to things like brightness, grids affect this, and artifacts will affect this as well. And then just remember, key factor affecting brightness and contrast in a digital system is the computer software. For brightness, it's going to be our monitors. How are our monitors set? Are they really bright? Is there a lot of background light that's super bright that's making it difficult to see my monitor? And then contrast is going to be our lookup table, our window width. However, we have to have signal reaching our detectors. We have to have a base quality technique so that that software can do its job. Okay, so spatial resolution, again, the recorded sharpness of structures on an image, detail, resolution, sharpness, definition. It's expressed in line pairs per millimeter. And these are going to be things that are geometric factors or your mechanical factors. So all the images over to the side are kind of showing these geometric factors that we've talked about, or the mechanical factors. So SID, or source to image distance. So as SID increases as my tube moves further away from my image detector, my spatial resolution is going to increase. And this is a direct relationship. The reason this is happening, and if you look at this picture here, the one in the middle, you'll notice how this shadow here, and we can think of our x-rays as bone shadows, this circle is more true to what the object actually is. And so what you'll find, and you'll notice this especially once you get to lateral C-spine images, which we're getting to, you're getting close, you guys. You'll notice that our SID increases to essentially counteract the fact that we have so much object to image detector distance. So as source to image distance increases, I get a more true representation of my part, and that is going to increase my spatial resolution. So SR is going to stand for spatial resolution. OID, so object to image distance, as OID increases, we're increasing magnification. Look at how different the shadow is from my actual object. So my spatial resolution here is going to decrease. This is going to be an inverse reaction. Focal spot size. So focal spot size, as it increases, so we have a small focal spot, we have a large focal spot. And this relates to the line focus principle. So if I have a smaller focal spot, I am going to increase my spatial resolution. So small focal spots, or focal spot size decreases, I increase spatial resolution. And then my example here is focal spot size increases, spatial resolution is going to decrease, so that's an inverse reaction. I believe I have an image of this on the next slide. If not, I know there's stuff in the notes that you received from Amy about this. So please look over your line focus principle and how that relates to spatial resolution. So next are your mechanical factors and their relationship to spatial resolution. So del size, del pitch. So as my del size increases, as that detector element pixel essentially increases, as that size gets bigger, my spatial resolution is going to decrease. We've talked about this a million times. So as pixel or del size increases, spatial resolution decreases, it suffers, and so inverse reaction there. However, when we get to matrix size, it's going to change. So as matrix size increases, so let's say, here we go, these lovely blue circles up here. So I have a smaller matrix size, even though I have 2.54 centimeters, which is an inch, even though I have a matrix here that the field of view is an inch by an inch, and an inch by an inch, my matrix size here is smaller because I have less pixels. So here I have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So this is a 10 by 10 matrix, which gives me 100 pixels here. And now I have 1, 2, 3, 4, 5, 6. I'm going to assume it's 20, so you guys don't have to hear me count. So 20 by 20. So now I have 400 pixels in here. So huge difference in the matrix size. So I've gone from 100 to 400, even though my field of view hasn't changed. But now this is a larger matrix. So matrix size has increased, and now this looks more like a circle than this almost diamond looking structure here. So as matrix size increases, my spatial resolution increases, and I have a direct relationship. Spatial resolution is decreased by motion. Trabecular bone is not going to be visible when I have a lot of motion. So if you're ever encountering a patient and you're noticing that you're getting a lot of motion on your images, make sure that you provide some way for them to stabilize. What kind of assistive devices do you have laying around? Do you have a walker? Do you have a sponge that they can rest on? What do you have? Scatter radiation does not, I repeat, scatter does not affect spatial resolution. It is going to affect your contrast. If I increase my MTF, I'm going to increase my spatial resolution. Remember, 1 or 100% is ideal, but that is never actually possible. Geometric factors, I have SID, OID, and focal spot size, so source to image distance, object to image distance, and focal spot size. Here is my line focus principle, so relating to my focal spot size, as I was talking about in the last slide. So source to image distance, as SID increases, my spatial resolution is going to increase. So as my tube gets further away from my image detector, the better my spatial resolution is going to be. Object to image distance, OID, as that increases, spatial resolution is going to decrease. And so please take a look over here. So if you notice, I don't have a very long SID here, and I'm going to get an image that has decreased spatial resolution in comparison to this one, where I have a better representation of my actual object. This is going to be pretty magnified, and you can see how the angles here will shoot this out a little bit further on the detector, versus here, this is going to be more true to size. And then let's take a look at this one that has a lot of OID. I am going to have a ton of magnification, even though I have a longer SID. But just because this is so far away, I am going to see increased magnification. Increased OID is going to decrease my spatial resolution. Focal spot size, so line focus principle over here. So if my focal spot size is smaller, I essentially only have like 1 point coming out on this side and 1 point coming out on the other side. So I am going to get a nice sharp image. However, when I have a larger focal spot size, what's going to happen is X-rays are going to come out and they're going to shoot in a cone like this, but they're also going to shoot in more of a wide cone like this one. And so you're going to end up seeing a bit of blur at the edges. And so this is going to have a decreased spatial resolution in comparison to this one here. And then distortion. So for shortening, elongation, motion, I don't really have a great picture of motion on this slide, but here's what obviously I want the bone to look like, and then what would happen if I had angle that would cause foreshortening or elongation. And essentially what's happening is at one end, I'm getting magnification, I'm getting more object to image distance, and so if I increase distortion, I am going to decrease my spatial resolution here. All right, mechanical factors. Hopefully all of this is a review for you guys, but just to go over it one more time, pixel size and pitch, also del size and pitch is related here. I gave you opposites on both of these, so notice that if pixel size, pixel pitch increases, spatial resolution is going to decrease. This one is saying the opposite essentially. So as del size and pitch decreases, spatial resolution is going to go up. Oh, sorry guys. Fill factor. So fill factor, as long as fill factor is increasing and I am not losing or increasing my pixel sizes too much to account for an increased fill factor, my spatial resolution is going to increase. Matrix size, we just went over it. As matrix size increases, spatial resolution is going to go up because my pixels or my DELs have to get smaller to fit within that field of view. And then modulation transfer function. This is how spatial frequency is expressed. As MTF goes up, spatial resolution goes up. And remember, this green is your sensing area, and it is sensing area to non-sensing area that gives you your fill factor. Things in the non-sensing area are going to be things like capacitors, wires, electronics, things like that. Contrast resolution, so ability of an imaging system to demonstrate small changes in tissue densities. Now, you'll notice that I've used this picture multiple times. The first time that I'm using it, I'm talking about spatial resolution because you can actually see the individual pixels in this image. So you can actually see the matrix here. However, what I am demonstrating in this slide is going to be, I can tell the difference in density. I have different shades of gray from here to here, from here to here, from here to there. So this is in the chest, so this is looking at ribs overlying each other and overlying the lung. So I can distinguish densities that are adjacent to each other. So bit depth is going to be the maximum range of pixel values our computer or our monitor can display. And this also relates to how they can store it. Something I do want to mention to you guys that I haven't really brought up yet is that the more information an X-ray has, so the more bit depth it has, the increased spatial resolution that it has, the larger the matrix is, the more information it has, the more space it is going to take up within a system. So think of this like phone memory. If I have a phone, if I bought a cheap cell phone and I took, or somebody sent me an image and it had a lot of details in it, and it was really large, it had a lot of like megabytes, gigabytes, that kind of thing. My phone might not be able to store it, or it would take up all of the storage space in my phone for just that one picture. Versus if I had a picture that didn't have all of these details, it was kind of a crappy image, it wouldn't take up as much space. So if you ever see questions about that, increased bit depth, increased spatial resolution, all those kind of things are going to increase the amount of storage space an image needs. CTs, MRIs, those exams take up so much space because they have multiple slices and a lot of detail and a lot of information versus just one X-ray. So just a little tidbit of information there. So BD, bit depth. So as my bit depth increases, contrast resolution can increase. Remember, this is based off of what I'm imaging. So if I'm imaging chest X-ray, if I have increased bit depth, I will likely see an X-ray of a chest that demonstrates a lot of shades of gray as long as my technique is correct. Versus if I take an X-ray of a femur, I'm not going to see as many shades of gray. I might see something more like this in a femur X-ray, whereas a chest X-ray, I'm going to see something like this. But even with my femur X-ray, I have this availability. I'm just not using it because that's not what the part is showing me. Noise. So noise is anything that interferes with the formation of an image. So that could be quantum model or quantum noise, meaning I didn't have enough technique to display what I need to display. Noise could be an artifact, and that can be caused by a myriad of different things. So if quantum model increases, my contrast resolution is going to decrease, and this is kind of demonstrated here. So here I don't have enough signal. I have quantum model, and so I don't have, like I have a lot of bright white here. I have some shades of gray in here, and then I have the dark area that is just tissue versus this. So this is increased contrast, short scale, high contrast. And then this is going to be long, decreased, low. So I have more shades of gray in this hip. I don't have as much noise. I have more signal that got through to my detector. And then exposure latitude, dynamic range. As exposure latitude increases, contrast resolution is going to increase because I have the ability to detect a lot more X-ray and actually turn it into a usable image like this. So this is demonstrated in this little chart here. So this dotted line represents what CR and DR could do. So I can, so if this is where I can start detecting things on film, all right, I can start detecting things about here on CR or DR. And then if this is where they end on film, well, okay, this is where it would end on CR/DR. So if you notice, this happens very fast with film, but with CR/DR, it is gradual. This is encompassing all those different intensities, all those different exposure values that I can use. So that's what I'm talking about with exposure latitude. All right, brightness. This refers to the appearance of a digital image on a display monitor and represents density in the patient. So something super bright, and even in this one, this is super bright. Super bright areas represent something that is super dense in the patient. Something that looks, so this is not as bright. This is more saturated, or you could even say that this is more dense on the display monitor. But this area here, these darker areas, that's the air, which is not dense in the patient or technically outside the patient. So increased brightness represents increased density in my part. So make sure that you recognize that distinction. If something is super bright, like metal, it represents something that is super dense within my patient. If I have decreased brightness, I am going to see decreased visibility of detail on the monitor. So if you look this first image here, it's much harder to actually distinguish details. And that is because it's dark. You can't really look at things versus this one's way too bright. And then these are kind of the Goldilocks images down here. If I have excessive brightness, then I'm also going to lose visibility of detail. If I have the monitor set way too bright, or if I have my window width messed up, I have it either opened or closed too much, I'm either going to get something that's really dark or really bright. If I don't send through enough technique, I'm going to get something that looks like this. If I send through too much technique, I'm going to get something like this. Ambient brightness, so ambient being around us. This is going to be room lights. This can also have an effect on visibility of detail. Too bright and visibility of detail is decreased. That's why X-ray techs live in dark rooms. It is so that we can see our screens clearly and actually pick up on specific details. That's why Dr. Davidson and the RPAs and all of our reading rooms are windowless areas that are dim. Also, always make sure you look at the monitor straight on. Viewing at an angle, it can cause loss of visibility. And I'm sure you've probably seen this on TVs or even some of the monitors that we use in the hospital. If you look at an angle, things just don't display correctly as if you were looking straight on. Grids. So remember, we want to use grids once we get to about 80 kVp. We start considering it as we're reaching 80 kVp. And this is going to be used for parts over 10 centimeters. So this could be an actual grid that we're putting onto our detector, or it could be a virtual grid. So virtual grids are going to essentially use, and we've talked about this before about algorithms and how our histogram analysis and lookup table comparison works. So essentially, a virtual grid does kind of the same thing as it works using a lookup table. And so it takes your image and it says, oh, well, this is a femur, so here's the shape of my histogram for a femur. Let me make this femur x-ray look like this lookup table. And so that's kind of how the virtual grid works. This is a display of, obviously, an actual grid that you would put on. With a grid, if you add a grid and you adjust your technique appropriately using the specific grid ratios, your visibility of detail is going to increase. So if you use a grid, visibility of detail increases if you use the correct technique. If you do not, you are going to end up absorbing all of the x-ray that you would use to actually get a diagnostic image, and you would end up with something that looks really foggy, really bright. So make sure if you're using a grid, you adjust your technique accordingly. All right, and then artifacts. So artifacts are going to detract from visibility of detail from spatial resolution. This is going to be extraneous information on the image that's interfering with us being able to see what we actually want to see. So these are going to be things like clothing or accessories. So patient has buttons, has necklace still on. They forgot glasses in their front pocket. They have a key in their hoodie pocket. White borders, we've already kind of talked about how white borders affect exposure field recognition and how it can cause your histogram analysis and comparison to your lookup table to malfunction, and then you get a super foggy image. Data drop or data clipping. So this one we'll see a lot of times, especially with overexposures. If let's say I'll use a pelvis as an example, because this is probably the most frequent place that I've seen this happen. If I overexpose a pelvis, I am going to send too much technique. I have too much signal, and so the values of interest get a little skewed. And so what ends up happening is when the histogram gets equalized, it starts clipping out values that I actually want to see. And so it'll clip out maybe my iliac crests or my ASIS. And that information will just be gone. It'll look like the pelvis is kind of like eaten away at the top. And so this is really concerning. We want to make sure that data drop, data clipping doesn't happen. So all this is, especially when you have overexposed images, make sure you're really paying attention and you don't see any data clipping or data drop. Something else that can happen when things get really overexposed is you can see lines on your x-ray. They can look like this. They can be vertical. This one is really showing an incorrect CR plate reader. This is an artifact that you would see in a CR plate reader, but it could look kind of like this, where you just see lines of information that's missing. And so that can happen in overexposure. Obviously, the image would be super dark if it was overexposed. Like I said, this is technically a CR plate reader malfunction, but it can happen on indirect and direct image receptors. If you overexpose, the foot and the knee or that's an elbow, would just be really dark, and then you would see some lines of missing information. Scratches, dust, wear, age, artifacts that happen on a CR plate. You may see dead pixels on DR plates. Backwards IR, here's an example of that. It'll look more like a galaxy on your DR plates. And then incorrect algorithms. So here's an example of this. This is a chest x-ray run under like a femur or more bony anatomy like this algorithm. So clothing and accessories, obviously in this instance we would want to repeat, especially if we're really concerned about whatever's going on in the abdomen here. If artifact is like over here and it's not affecting, then if it's not really changing our algorithm or making anything look too out of whack, then obviously I wouldn't repeat that. White borders, we can shutter to get rid of those white borders and allow our system to reprocess the lookup table correctly. Data drop or clipping, really with those, you're to a point where you're so overexposed that you have lost information. And so there's not too much that we can do on the backside to rework our equalization. So we actually have to readjust our technique and take images again when we have data drop, data clipping, or we see lines coming across because we've overexposed. Scratches, dust, wear, age. If you see anything that is obscuring anatomy that you want to see, you need to replace the detector and then you can re-expose your patient. Do not use the same detector if you are noticing something related to scratches, dust, age, wear, dead pixels. Sometimes as detectors age, lines will start showing up. And that is essentially a line within your TFT array has died. The gates that allow them to send their information are either not opening or closing correctly. And so that's just kind of what happens as these things get old. Backwards IR, obviously you're going to have to repeat that. Please make sure you flip your detector. And then incorrect algorithms. These typically you don't have to repeat. You just change the algorithm that it's under. We can definitely work on that in clinic. So any artifact is going to decrease your visibility of detail. Obviously there are more artifacts, so Moire artifact here. For this one, first let's start here. Any double exposures or anything like this, please repeat. Anything with Moire artifact, especially if it's CR plate reader, there's no hope in fixing that image. You're going to have to change your grid ratio, increase your grid ratio, adjust your technique, and repeat that image. And then as far as DR plates, you're not going to be able, you're going to have to repeat this. And you're going to have to either add a grid and adjust technique, or you're going to have to adjust the algorithm that it's run under. As far as spatial frequencies, I'll be honest with you, I don't even know how to change that. But I will definitely do my research to find out more. And then make every attempt to have your marker on your image. These are legal documents. You should always have the anatomical side um, exposed onto your image, and then that anatomical side marker should have your initials on it. There should be a patient identifier, and this gets put on by our actual systems. Our computer does it for us. They used to have to expose it onto the film. And then date of the exam. All right, I'm going to stop here for part 1 and then make sure you check out part 2.